Groundbreaking findings released in a major medical journal just 21 days ago are set to overturn everything you have ever been taught about healthy blood pressure. For generations, the medical establishment has repeated a single, unchallenged mantra. The gold standard is 120/80. That is the target. That is the universal benchmark everyone must strive to achieve. The common belief was that driving that number down as far as possible equated to superior health. Yet this fresh investigation from the Journal of the American Medical Association exposes a startling and dangerous flaw in that logic. For older adults past the age of 65, aggressively chasing a reading of 120/80 might actually be hazardous. It could be the hidden trigger behind debilitating tumbles, sudden brain attacks, and premature mortality. After spending 2 decades inside the operating room as a cardiac surgeon, I am ready to reveal the unfiltered reality about arterial pressure in our later years. But I am withholding the precise safe zone measurement for the moment. If I disclose it immediately, many of you will scribble it on a notepad, close this window, and miss the life-saving context. You must first grasp the physiological reasons why this number diverges sharply for the aging body. You need to witness the catastrophic cascade that unfolds when arterial pressure plummets too severely in a senior. You require the full panoramic view before I hand you the exact numerical range you should personally be pursuing. Before I even hint at the correct value or offer a single clue, you must visualize the brutal outcome when a senior citizen successfully hits the 120/80 bullseye. You need to internalize the brutal truth that for the elderly body, a lower reading is not automatically a better one. Sometimes, a low reading is a lethal one. Drop your current pressure digits and your age into the comment section below right now. I need to observe what ranges real people are living with and how old they are. This data is extraordinarily revealing. Let me introduce you to Eleanor, because her devastating journey will permanently recalibrate how you perceive cardiovascular health. Eleanor had celebrated her 78th birthday when our paths first crossed. Her high blood pressure diagnosis had landed a full decade prior, back when she was 68. Her primary care physician initiated pharmaceutical treatment without delay, beginning with a single daily tablet. At the time of diagnosis, Eleanor's baseline reading hovered around 152/88. Following 2 months of medication, the numbers retreated to 138/82. Her physician expressed satisfaction. "We are making solid progress," he declared. "But we must push you all the way to the finish line at 120/80. That remains the non-negotiable goal." He titrated the dosage upward. 2 more months elapsed, and Eleanor's reading settled at 128/76. An improvement, certainly, but still shy of the mythical 120 target. Her doctor layered on a secondary agent. "We truly desire you at that pristine, ideal reading," he insisted. 120/80 is your safe harbor. It is where your vulnerability to cardiac events and cerebral accidents plummets to its absolute lowest point. Eleanor placed total faith in her physician. She had trusted his judgment for 2 full decades. If he decreed that 120/80 represented the Holy Grail, she would pursue it with total dedication. She swallowed both prescriptions with religious devotion and monitored her vitals with a home cuff consistently. After another 60 days on the dual medication protocol, her body registered at 122/78. She was practically kissing the goal line. Her doctor radiated enthusiasm. "Absolutely flawless," he beamed. "This is the exact sweet spot where we want you to reside. Maintain the course." Initially, Eleanor perceived little change, perhaps a whisper of fatigue, but she had lived 78 years. A degree of weariness felt like a standard feature of aging, nothing alarming. Then, a peculiar sensation began to intrude. Anytime she rose from a seated posture, a wave of vertigo would wash over her for a few seconds. The room would lurch violently. She needed to brace herself against a wall or a piece of furniture until equilibrium returned. She brought this worrying symptom to her doctor's attention. "That is likely just a benign product of advanced years," he responded. "Your vascular conduits have lost their youthful elasticity. There is a brief lag moment while your system adjusts to gravity when you stand. Totally normal. Simply rise more gradually. Take your time getting upright. Eleanor adhered strictly to this advice. She transitioned from sitting to standing with deliberate slowness, almost in slow motion. Yet the spinning sensation refused to retreat. It ambushed her every time she left a chair, crawled out of bed, or got up from the sofa. A quiet dread of the simple act of standing began to bloom inside her. Her movements became tentative, guarded, and excessively cautious. Her daughter observed the change immediately. "Mom, you are navigating the house like a frightened person. What is causing this?" Eleanor confessed the dizzy spells. Her daughter urged her to revisit the doctor with urgency. Eleanor phoned the clinic and left a message. A return call came from the nurse. The doctor's assessment is that as long as your pressure readings stay optimal, the dizziness is almost certainly age-related. Ensure your hydration levels are adequate. Drinking more water can sometimes mitigate the problem. The dizziness persisted relentlessly. Then, one morning, roughly 3 months after her pressure had been forced down to 122/78, Eleanor woke with a pressing need to use the restroom. She eased up to a sitting position on the edge of the mattress, swung her legs over the side, and stood. The room detonated into a chaotic spin. She sensed her knees dissolving beneath her weight. She clawed desperately at the nightstand, but grasped only air. She went down with tremendous force. On the trajectory downward, her right hip slammed with full impact against the sharp wooden corner of the nightstand. She crumpled onto the hard floor, immobilized. A searing, white-hot agony erupted from her hip. She could not stand. Eleanor's husband jolted awake to the thunderous crash. He rushed to her side and found her weeping on the floor, utterly unable to move her right leg. He dialed the emergency line. The paramedics arrived swiftly. They assessed her pressure while she was lying flat. The systolic reading was 118/74. They measured it again with her torso elevated. It had crashed to 94/62. Finally, they checked it with her standing upright. The shocking result was 82/54. This was a severe case of orthostatic hypotension. Her arterial pressure was taking a catastrophic nosedive every time she changed spatial orientation. The pharmaceutical cocktail had depressed her baseline pressure so aggressively that her body could no longer sustain adequate cranial perfusion when she was vertical. Her brain was being starved of oxygen-rich blood the moment she stood up. That oxygen deficit was the root of the chronic dizziness, and that dizziness had now caused a catastrophic tumble. Hospital radiography confirmed a completely fractured hip, snapped clean through. Surgical intervention was unavoidable, a full hip replacement. Yet Eleanor was 78 years old. Invasive surgery at that stage of life carries perilous risks. The orthopedic surgeon laid out the grim possibilities: systemic infection, thrombotic clots, pulmonary complications, and adverse reactions to general anesthesia. But there was no alternative pathway. Without the operation, Eleanor would be permanently confined to a bed or wheelchair. They booked the operating theater for the following day. The surgical procedure itself was executed without any technical complications. The real battle was the aftermath. Eleanor languished in the hospital for a solid week before being transferred to a skilled rehabilitation facility. She spent 3 grueling weeks there, fighting to retrain her body to walk. Agonizing physical therapy sessions dominated her schedule twice a day. It was exhausting and deeply painful. Before the disastrous fall, she had enjoyed complete autonomy, managing her own household and handling every personal task. Now, she required assistance for the most intimate aspects of daily living: dressing, washing, and moving. She experienced a sensation of having aged 2 decades in a single night. After 4 long weeks, Eleanor was finally discharged to her home. But the woman who returned was a hollowed-out echo of the original. She was haunted by fear. She was terrified to ambulate without the security of a walking frame. She was petrified of moving too swiftly and afraid to be left in solitude. Her daughter had to temporarily relocate to her house to provide constant support. Eleanor's entire universe contracted drastically. Prior to the incident, she had lived vibrantly. She drove herself to the grocery, attended worship services, and maintained an active social calendar with friends. Now she was a prisoner inside her own living room, crippled by anxiety and muscular weakness. And here lies the true, heartbreaking tragedy. 6 months after the traumatic hip fracture, Eleanor developed a raging case of pneumonia. Her fear of movement had led her to remain sedentary, sitting or sleeping for dangerously prolonged periods. This immobility allowed fluid to silently pool and stagnate inside her lungs. A respiratory infection in a 79-year-old with drastically reduced physical reserves is a dire medical crisis. It is extremely dangerous. She was rushed back to the hospital and placed on intravenous antibiotics and supplemental oxygen, but her lungs were too weak to expel the infectious material. Her body had become too deconditioned after half a year of severely restricted activity. Eleanor passed away just 3 days after being admitted. Her daughter was consumed by a volatile mixture of grief and rage. "My mother was perfectly fine until they cratered her blood pressure," she later told me in a raw, emotional confession. "She was dynamic, self-sufficient, and filled with joy. Then they pushed her to 120/80, and the falling began. That single fall ignited a chain reaction that culminated in her death, all because her pressure was artificially suppressed to a dangerous low. Her physician had celebrated 120/80 as a perfect score. How can a perfect number be the instrument of death? That question sits at the core of this entire crisis. How can a textbook perfect blood pressure value terminate a life? The answer is brutally simple. 120/80 is not a universally perfect fit. It is especially ill-fitting for the older population. For individuals navigating their late 60s, 70s, and beyond, pursuing 120/80 can be a direct path to danger. It can generate the exact sequence of disasters that swallowed Eleanor whole: a violent fall, a major skeletal fracture, rapid systemic decline, and death. Now, type the word dizzy in the comments if you experience lightheadedness upon standing. Leave that word if this happens to you on a routine basis. This is a critical alarm bell signaling that your arterial pressure may have been driven too low for your specific stage of life. Eleanor's narrative should frighten you at a primal level, but it should also ignite a righteous fury within you. Her death was entirely preventable. If her primary doctor had recognized that 120/80 was excessively low for a 78-year-old woman, if he had aimed for a more physiologically appropriate, moderate reading, Eleanor would still be alive today. She would still be independent, still active, still holding her grandchildren. But he lacked this crucial insight. He was blindly adhering to obsolete, one-size-fits-all protocols that fail to factor in chronological age and the singular vascular biology of elderly adults. So, what is the correct, safe blood pressure target for a senior? What numerical sanctuary should you be aiming for? I am about to lay it out for you, but first you must learn precisely why the aging cardiovascular system is so drastically different. Why the rules that govern a 40-year-old body are utterly inapplicable to a 70-year-old body. Why 120/80 might be a dream for a middle-aged person, but a potential death sentence for an older adult. The first critical factor is vascular stiffening. As the years accumulate, your arterial walls progressively lose their supple, rubbery elasticity. They become rigid. This physiological hardening is clinically known as arteriosclerosis. Rigid pipes cannot expand and contract with the smooth grace of young, flexible vessels. When your cardiac muscle ejects a bolus of blood, stiff arteries fail to absorb the pressure wave as efficiently. This fundamental physics shift means you actually require a slightly elevated pressure to guarantee sufficient blood delivery to your vital organs, with the brain being the most critically sensitive. In a young person blessed with compliant, flexible vessels, a pressure of 120/80 is more than enough to secure robust cerebral blood flow, even during postural changes. But inside an older person cursed with rigid piping, 120/80 may be woefully insufficient. When they rise to their feet, those unyielding vessels cannot adapt with the necessary speed. Blood pressure nosedives, cranial perfusion plummets, the brain starves, vertigo seizes them, they crash to the ground. The second differentiating factor is baroreceptor sensitivity. These microscopic pressure sensors are embedded within the walls of your major blood vessels. Their job is to detect shifts in pressure and instantly relay signals to the brain, which then modulates heart rhythm and vessel diameter. In the young, these baroreceptors are lightning fast. The instant you stand, they sense the gravitational pressure drop and immediately order the heart to race and the vessels to clamp down. This elegant reflex sustains your pressure and keeps your vision crystal clear. But baroreceptors dull with the passage of time. They become sluggish and slow to react. When an older individual stands, these worn-out sensors lag significantly. If their resting pressure has been artificially driven down to 120/80 and their sensors are half asleep, they will suffer a profound pathological pressure collapse before their body can mount a rescue response. This is orthostatic hypotension, and it is the phantom that pushes seniors to the floor. The third reason involves pharmaceutical metabolism. The elderly liver and kidneys process chemical compounds far differently than those of the young. Renal clearance rates diminish. Hepatic detoxification pathways downshift. This means that antihypertensive drugs linger in the bloodstream far longer and bind far more aggressively in an octogenarian than in a 50-year-old. A standard dosage that is perfectly benign for a middle-aged patient can be overwhelmingly potent for a frail senior. It can depress blood pressure excessively, plummeting into dangerously low, life-threatening territory. The fourth major distinction is the shifting landscape of medical risk. In a younger demographic, the primary menace of hypertension is the slow-burning arterial damage that accumulates over the span of decades, leading to heart disease, renal failure, and clot-based strokes. But for the very old, the immediate acute peril of a catastrophic tumble due to hypotension often far outweighs the distant theoretical threat of mildly elevated systolic pressure. A devastating fall can kill an 80-year-old within a few short months. Meanwhile, a stable pressure of 140/85 might remain entirely asymptomatic for many years, perhaps forever. The strategic calculus completely flips. For a healthy 50-year-old, striving for 120/80 is a logical long-term investment. They have decades of life ahead to protect. But for a fragile 80-year-old, preventing a bone-shattering accident takes absolute precedence over acing a blood pressure exam on paper. You are undoubtedly itching to hear the definitive number. What exact digits should appear on your monitor if you are over 65, over 70, or north of 80? I am going to give it to you, but first, we must scrutinize the raw evidence from the scientific literature. The data is genuinely surprising, and it flatly contradicts the dogma most practicing physicians absorbed during their training. The traditional recommendation, the dictum that every adult needs to hit 120/80, was constructed from clinical trials dominated by middle-aged participants, people in their 40s, 50s, and very early 60s. Those studies convincingly demonstrated that lowering pressure reduces heart attacks and strokes, and for that specific demographic, that is absolutely true. But vanishingly few high-quality studies have isolated the truly elderly, the 75-plus, and the 80-plus cohorts. The scant few that did study them stumbled upon a deeply counterintuitive discovery. A landmark investigation known as the SPRINT trial, published in 2015, examined intensive pressure reduction. It pitted a target of less than 120 systolic against a target of less than 140. The headline result was that the aggressively lowered group had fewer cardiovascular incidents. This single trial ignited a global stampede to drive pressure as low as possible in everyone. But here is the massive, glaring blind spot. The SPRINT trial systematically excluded precisely the types of older patients who fill real-world clinics. They threw out anyone with diabetes, anyone who had experienced a previous stroke, and anyone who was physically frail or unable to walk briskly. So, the findings cannot be cleanly extrapolated to the typical 80-year-old grandmother with multiple medical issues. Then came the explosive analysis I cited at the very start of this video, published merely 3 weeks ago in the Journal of the American Medical Association. This investigation tracked 15,000 adults, all aged over 75 years, a representative sample of real-world elderly people, including the diabetics, the stroke survivors, and the frail individuals the SPRINT trial had ignored. The researchers correlated long-term outcomes with average arterial pressure readings, and their discovery sends a wrecking ball through conventional wisdom. Among the over 75 demographic, the people with systolic pressures hovering between 130 and 140 enjoyed the absolute lowest mortality rates. They lived longer than the group kept below 120. They also lived longer than the group soaring above 150. The sub-120 cohort suffered markedly higher rates of injurious falls, sudden fainting spells, acute kidney failure, and all-cause death. The group above 150 faced elevated risks of brain bleeds and cardiac attacks, as expected. But the biological sweet spot, the pressure zone associated with maximum survival and the highest quality of life, was a systolic window of 130 to 140. The research team was stunned by the implications. The findings detonated the old paradigm. But upon deeper physiological analysis, the results made perfect evolutionary sense. For aging bodies, especially those past 75 years, maintaining a pressure slightly higher than the old-school target ensures robust perfusion of vital tissues, most critically, the brain. It wards off the orthostatic crash that occurs upon standing. It dramatically lowers the risk of a life-altering tumble, and these tangible, immediate survival benefits massively overpower the hypothetical increase in heart attack risk that might come from that mildly elevated pressure reading. I am still holding back the exact one-size-fits-all target number because it is a myth. The safe harbor shifts depending on your specific vintage, your concurrent illnesses, your physical robustness, and your body's sensitivity to medications. The pressure that is a safe haven for a robust 68-year-old could be a danger zone for a fragile 82-year-old. Let me tell you about Harold, aged 72, because his clinical journey demonstrates why personalized calibration is absolutely everything. Harold presented with a baseline pressure of 146/88. His physician was determined to hammer it down to 120/80, so he initiated pharmaceutical therapy. After 2 months, Harold's monitor displayed 124/78, almost a perfect score. Yet Harold felt utterly miserable. He was plagued by profound lethargy, embarrassing dizzy spells, and an inability to focus his thoughts. His subjective quality of life had been annihilated in pursuit of a cosmetic number. I conducted a thorough review of Harold's full health picture. He was otherwise in great shape, physically active, with no diabetes, no evidence of coronary disease, and perfectly healthy kidneys. For a man of Harold's profile, a raw pressure of 146/88 was likely a benign, age-appropriate change that posed minimal acute danger. Meanwhile, the side effects of the medication were crushing his spirit. We strategically dialed back his prescription strength, allowing his pressure to naturally settle back up to a comfortable one, 36/82. The transformation in Harold was instantaneous and dramatic. His physical energy surged back. The dangerous lightheadedness vanished completely. His cognitive fog lifted, and his new steady pressure, while technically higher than the outdated 120 benchmark, was perfectly safe and physiologically appropriate for a healthy 72-year-old man. But now, let's contrast Harold with Margaret. She was also precisely 72 years old. But Margaret carried a heavy burden of medical baggage, a long-standing diabetes diagnosis, a prior heart attack that had scarred her myocardium, and significantly impaired kidney filtration. For Margaret, a raw pressure of 146/88 was a ticking time bomb. We absolutely needed to bring it down. However, we could not recklessly drive her all the way to 120. That would have been dangerously low, given her delicate vascular and renal status. We carefully negotiated a middle ground and settled on a target of 130/80. Through meticulous, gentle medication titration, we achieved that exact mark. Margaret tolerated the new regimen beautifully. She had no dizziness and no fatigue. More importantly, her statistical risk of another catastrophic cardiac event or stroke was meaningfully lowered. Here, we have two human beings of identical chronological age, but requiring radically different target numbers, simply because they were entirely different biological organisms with unique risk profiles. Now, drop a comment with your age and flag whether you have a history of diabetes, heart disease, or kidney disease. Format your comment like this: age 72 with diabetes and heart disease, or age 68 with none, or age 80 with kidney disease. I need to see the landscape of conditions we are navigating so I can contextualize what pressure ranges are genuinely suitable. Allow me to also share the story of Ruth, because her case illuminates the opposite extreme of the spectrum. Ruth was 83 years old and profoundly frail. She carried a heavy diagnosis list, including diabetes, congestive heart failure, and advanced chronic kidney disease. Her pressure consistently clocked in at a lofty 168/92. Her referring physician wanted to wage an aggressive pharmacological war on that elevated number. I vehemently disagreed. For a fragile patient like Ruth, aggressively tanking her pressure would likely invite more harm than benefit. She was already physically weak, already unsteady on her feet, and already perched on the precipice of a catastrophic fall. Further lowering her pressure could easily have been the final nudge that pushed her over that cliff. We made a conscious, strategic decision to leave Ruth's pressure hovering around 160/90. This reading is alarmingly high by traditional standards. But for Ruth, considering her age and fragility, it represented the safest possible equilibrium. She stayed clinically stable. There were no devastating falls, no panicked hospitalizations. Her quality of life remained preserved, and she could continue living on her own terms. Her primary doctor remained uncomfortable looking at that high number on the chart, but Ruth was physically comfortable. She felt reasonably well, and most vitally, she remained autonomous. 5 years later, Ruth was still alive, still in her own home, and still independent. Her pressure had stubbornly persisted around 160/90 the entire duration. I am deeply convinced that if we had aggressively pushed to force her down to 120, she would have suffered a devastating hip fracture, entered a spiral of decline, and likely died much earlier. This challenge is not confined to the extremely old or the extremely frail. Even healthy, vibrant seniors deserve higher, safer targets. Let me introduce you to William, a spry 70-year-old. He was in excellent health, physically active, and played 18 holes of golf twice weekly. He had no significant chronic medical conditions. His pressure ran at a stable 142/84. His physician was adamant he needed medication to hit 120/80, but William felt absolutely fantastic at his natural pressure. He had zero symptoms, boundless energy, and a rich quality of life. I counseled William bluntly. For a man of your health profile, a systolic reading of 142 is likely entirely harmless. You are active and have no end organ damage like diabetes or coronary disease. The statistical risk posed by that moderate reading is negligible. The potential benefit of slamming your pressure down to 120 with pills is tiny, but the risk of introducing nasty side effects like fatigue and dizziness from aggressive treatment is significant. Let's leave well enough alone. William exhaled with profound relief. He had dreaded the prospect of a daily pill. He was content with his current state of health. We monitored his numbers every few months. They remained stubbornly steady around 140/84. He encountered no complications. William continued to conquer golf courses, travel, and savor his retirement. Now, I must clarify a critical distinction between the two numbers in a pressure reading. The vast majority of the conversation revolves around the systolic value, the top digit. That is the pressure generated when the ventricles contract forcefully. The diastolic value, the lower digit, is the residual pressure in the arteries when the heart muscle is relaxing and refilling. For the senior population, the systolic value carries disproportionately greater weight. As the body ages, the systolic number naturally creeps upward due to the loss of aortic elasticity. The diastolic number, however, often stays flat or may paradoxically drop. This dynamic widens what we call the pulse pressure, the gap between the top and bottom digits. For instance, a 70-year-old might post a reading of 150/75. That yields a pulse pressure of 75. This is a perfectly normal hemodynamic pattern for their age. It is a direct fingerprint of stiffened vascular pipes. The real danger flag you absolutely must watch for is a diastolic pressure that plunges too low. If the diastolic number sinks below 60, it can critically compromise the flow of blood into the coronary arteries during the heart's resting phase. This can trigger ischemia. So, while you may wisely accept a systolic value of 140 in an older person, you must simultaneously ensure the diastolic pressure doesn't drop off a cliff. Ideally, keep that bottom number hovering above 65 or 70. Recall Eleanor's numbers right before her tragic tumble. Her seated pressure was 122/78. The systolic was lower than ideal for her age, but that diastolic of 78 was acceptable. The fatal flaw was the positional crash. When she stood, her systolic cratered to 82 and her diastolic collapsed to 54. A diastolic pressure of 54 is profoundly perilous. Her coronary arteries were being robbed of adequate blood flow during diastole. That starvation compounded the dizziness and virtually guaranteed a fall. Let us now focus on the brain, the organ most vulnerable to low pressure in the elderly. The human brain is perched at the very top of the body. Blood must fight a relentless uphill battle against gravity to reach it. In the young, pliable vessels and ultra-sensitive baroreceptors make this a trivial task. But in the elderly, with stiff pipes and dulled sensors, sustaining cranial blood flow requires a certain minimum pressure head. If the systolic pressure dips below roughly 110 in a senior, cerebral perfusion falters.